Hi, this is a presentation on Caesarean scar pregnancy. My name is Suzanne Johnson and I'm a gynecologist from Southampton. During this talk we'll talk about section scars and niches, Placenta Accreta spectrum and postpartum hemorrhage, the definition of a Caesarean scar pregnancy with our experience in Southampton, some controversies, differential diagnoses and conclusions. A Caesarean scar pregnancy is a type of uterine ectopic pregnancy where the trophoblast implants in a Caesarean scar niche where there's no decidua. The incidence is around 1 in 2,000 pregnancies and the risk increases with the number of previous Caesarean sections. Most scar pregnancies fail in the first trimester, but those that develop beyond that develop into Placenta Accreta spectrum. What do normal section scars look like on ultrasound? In all of the presentation, my orientation is the same with the bladder here, so the patient's head is here and her feet are here. So in this image here, you can see one section scar and there's another one. This patient has had 3 section scars. And here's a little video clip of 2 normal Caesarean section scars in an anteverted uterus. There's one scar there, and one scar just there. So a normal intrauterine pregnancy in a uterus that's had a previous Caesarean section looks like this. There's the scar, there's an intrauterine pregnancy, and you can see that the two are quite some distance apart. So this is a normal intrauterine pregnancy. So what's a Caesarean scar niche? A niche is where the myometrium indented at least by 2 millimeters at the site of the scar on ultrasound, and it reflects poor healing of the uterine scar. It's very common if you infuse a bit of saline. About half of all section scars have a small niche, and factors in the development of a niche is not 100% clear, but it probably depends a bit on whether the surgery was done electively or as an emergency and at which stage of labour, possibly section technique, whether or not there was infection, and some maternal factors. So where is this niche? Here again is an anteverted uterus with the uterus pointing toward the bladder, and you can see that there's a niche here. There's a little gap where the myometrium has not healed properly. If the uterus is retroverted and pointing away from the bladder, the niche is here, still in the anterior wall. So how do you measure a niche? Well, this is an image of a niche, and here's a little video clip in the longitudinal plane going from side to side. You can see that there's this little area that's filled with fluid where the myometrium is not healed properly. Going into the transverse, you could see the width of it as well. This is how you can measure it. That's the length, and that's the depth and the width in the transverse plane. And you can measure the overlying myometrial thickness, residual myometrial thickness, taking care not to measure any bladder or any tissues here, and not to measure any decidua on this side. And then the adjacent myometrial thickness is just next to the niche. And the measurements of RMT and AMT give you an idea of how deficient this niche is. So what's the problem with niches? Well, if you have a large niche, and there you can see it again in an anteverted uterus, this can cause spotting because you can get an accumulation of menstrual fluid in the niche, which can then leak out during the rest of the cycle as intermenstrual bleeding. But it's also possible that this fluid that leaks from the niche might reduce embryo implantation in the endometrial cavity. The real problem comes when you have a pregnancy in a section niche, and that's when you develop a Caesarean scar pregnancy. So you have very thin myometrium in the niche. It's often mainly fibrous tissue, and there's no endometrium in the niche. So in a scar pregnancy, the placenta attaches itself deeply straight into the myometrium and near to large blood vessels. And here's an anteverted uterus with a niche, and you can see that the white trophoblast is in the niche just there, and that it's very close to the bladder and surrounding tissues and very large vessels which are near the surface of the uterus. And in this beautiful diagram from Silver, you can see that the placenta would normally implant onto some decidua that keeps it away from the myometrium, but where you don't have any decidua in the case of a niche, the placenta implant straight onto myometrium or into it or through it onto the serosa, and the degree is probably dependent on how thin the residual myometrial thickness is. And so that's called accreta, increta and percreta, and the three of them together are called placenta accreta spectrum. Basically, the placenta is abnormally adherent to the other tissues. This used to be called abnormally invasive placenta or morbidly adherent placenta, but it's now called placenta accreta spectrum. So the placenta is abnormally adherent to thin myometrium and fibrous scar tissue, and some large blood vessels develop in and near the placenta. And after delivery of the baby, the placenta doesn't separate, and if you have a manual removal at that time, the large vessels in the niche and the fibrous tissue which can't contract results in heavy bleeding, and that's a postpartum hemorrhage. And from this green top guideline from the RCOG a few years ago, we learned that placenta accreta spectrum is the second highest cause of hemorrhage, leading to hysterectomy in the UK. And the vast majority of placenta accreta are the consequence of low placentation into a previous section scar. So exactly what is a Caesarean scar pregnancy? It's a diagnosis we make on ultrasound in the first trimester, and it's where a pregnancy is implanted into the niche of the scar, into this deficient scar there. We diagnose this on transvaginal ultrasound with a partly filled bladder so that this part of the anatomy becomes more clear. You have to have some experience, and it's much harder to diagnose after about 7 or 8 weeks, because by that time this pregnancy will fill the endometrial cavity and it becomes much harder to say if it's a scar pregnancy or not. In 2016, this green top guideline gave us diagnostic criteria, and it's that the uterine cavity is empty, that the trophoblast is embedded at the site of the previous section scar, that there's thin or absent myometrium between the sac and the bladder, prominent colour flow, and an empty endocervical canal. So what does that look like on ultrasound? Empty uterine cavity, especially less than 8 weeks, that's there. Closed cervix and empty endocervical canal, like that. And then the gestation sac embedded at the site of the scar, and that means there's a negative sliding sign on a little bit of pressure, it's embedded. With thin or absent myometrium between the sac and the bladder, 1 to 3 millimeters. And functional colour Doppler flow, proving that the pregnancy is embedded and not just on the way out as a miscarriage might be. And there's an image of the colour Doppler flow showing that this placentation is actually embedded in this location. And there's some good papers for you to look at. So in a little bit more detail, an empty upper cavity and an empty cervical canal, and through this line you can realize the difference where the bladder attaches to the cervix. This is cervix and this is uterus above it, and so a scar pregnancy will be just above the line of the internal os. And here is the gestation sac in the niche with strong vascularity, thin overlying myometrium. And this is a really important sign. In early gestation, less than 8 weeks, you might see a triangular sac just there that fills the niche. We learned that from Ilan Timotrish. So this paper has only just come out, and it tells us how we can assess the colour Doppler flow in scar pregnancies. In between 6 to 10 weeks gestation, they used a PRF of 0.9 kilohertz, and then you can grade the colour score to 1, 2, 3 or 4, similar to in the IOTA systems for adnexal lesions. I've always used 0.6, sometimes 0.9, but I'll be using 0.9 from now on. Here's then a video summary of the diagnostic features of a scar pregnancy, and this is a longitudinal view of an anteverted uterus going side to side. You can see that the gestation sac is embedded very low, that the endometrial cavity is empty, that the cervical canal is empty. A little bit of pressure is not shifting this sac, so it's embedded there. It's not on the way out as a miscarriage. And so this fulfills all the criteria for a scar pregnancy: empty uterine cavity and cervix, the sac is embedded at the site of the scar, thin or absent myometrium, you can barely see the overlying myometrium there, and then functional flow on colour Doppler. So this is it before and this is after, and sometimes it's a little bit hard to see what's trophoblast and what isn't. When you put colour on, it becomes very obvious. So the difference between an anteverted and a retroverted uterus. So in an anteverted uterus, the Caesarean scar pregnancy is of course here, closest to the bladder, with the patient head here, feet there. And in a retroverted uterus, where the uterus points away from the bladder, the section scar pregnancy would be located there, as is proven with some colour Doppler. Again, it's embedded here in the area of the scar. So a scar pregnancy might just be an empty gestation sac, as in this case. We've got an empty uterine cavity, an empty cervical canal. This was embedded, it didn't move on pressure. The overlying myometrium is only 1 millimeter, that's very thin. And with colour Doppler, you can say that it's actually implanted there, possibly with some posterior placentation. And on repeat scan, this sac remained empty at 10 weeks, and she had an uneventful surgical management. So that's a failing scar pregnancy. Another example of a failing scar pregnancy is where there's trophoblast only, as in this example at 7 weeks gestation. This is a 3D image of an anteverted uterus with the empty endometrial cavity, and here is a mass of trophoblast anteriorly. This is it on 2D. You can see how really vascular this was. This is strong vascularity. And this patient was given methotrexate, and so 2 weeks later it's much larger and more vascular, and it then became infected, this residual trophoblast 2 months later, and after antibiotics the infection settled, but it had nearly resolved by 3 months. So what's our experience of scar pregnancies in Southampton? Here are some first trimester images of 10 scar pregnancies over the last decade. And top left, I've written the RMT, the residual myometrial thickness overlying the scar pregnancy, in yellow. And you can see that they're all less than 3.3 millimeters, and most of them are 2 millimeters or less. In these 10 in-niche scar pregnancies, they were all diagnosed early, apart from this one that was diagnosed a bit later. They were all delivered after 27 weeks, but sadly 8 of them by caesarean hysterectomy. One section, they needed a Bieling suture to stop the bleeding, and in one caesarean section she had a partial myometrial excision. The estimated blood loss, the average was just over 6 litres, and on histology 8 out of 10 of these had Placenta Accreta spectrum. So if we just look at one example particularly, and in the yellow letters this is the number of weeks gestation, here you can see clearly an empty cavity. The trophoblast is in the caesarean scar niche, the cervix is empty, and there's a live scar pregnancy there. By 7 weeks it's larger, and you can more clearly see the trophoblast in the niche. By 9 weeks the cavity is still empty, a little bit unusual because this would normally fill the endometrial cavity by about 9 weeks. By 14 you can see this very thin overlying myometrium. And you can see at the time of section is that this is the niche, and it's very thin. You can see the placenta through it, and it's developed these very large vessels in fibrous tissue with intact serosa. And at caesarean hysterectomy, you can see that the placenta is embedded straight onto serosa, and this was Placenta Accreta. So at other times you still have to be a little bit careful. If the scar is very high, like in this case, this lady had a caesarean section for failure to progress at 9 centimeters, so it's quite a high scar for that scenario. And when she became pregnant 5 years later, the lower edge of the placenta has extended over the well-healed scar, and the thickness was around 3.5 millimeters. You can see that it's actually embedded over the scar by Doppler, and she developed a small bilobe placenta with Placenta Accreta adherent to this very deficient old section scar. In this case, this lady had 2 prior sections, and at 6 weeks developed severe pain and heavy bleeding. She has a scar pregnancy there, you can see, with a myometrial thickness of 3.5 millimeters. Anterior placentation, and it's not a miscarriage. You can see it fulfills the criteria for a scar pregnancy, but don't stop there. The sonographer could see something behind the cervix, and it was separate from the left ovary. This was in fact a tubal ectopic, so that was removed the same day, and then the patient went to 27 weeks when she had spontaneous rupture of the membranes and ended up with a Caesarean hysterectomy with heavy bleeding. The histology showed Placenta Accreta. So this was a heterotopic scar pregnancy, a scar pregnancy and an ectopic pregnancy. Sometimes the uterine shape isn't normal, and we use this classification system from Jurkovic in 2003. And this patient at that time had had 3 Caesarean sections, and this pregnancy in the left horn resulted in a breach and another section. We saw the patient a year later, so she's now had 4 prior sections, and she had a live scar pregnancy. This is it on 3D. We don't use 3D to diagnose it, but the image looks nice there. It was a live scar pregnancy, and she had surgical management. A year later, she developed yet another scar pregnancy of uncertain viability this time, and this is what it looks like on 3D, and thin overlying myometrium again, and she had uneventful surgical management. You need to be careful with twin pregnancies. We've had 2 examples of that where the lower twin is a scar pregnancy. You can see the trophoblast is embedded in the niche, and this is the other twin, and it's embedded in this place. This is twin 1. This pregnancy failed, and the other pregnancy was delivered at 39 weeks with a little bit of extra bleeding compared to most cases. In this case, again, twin 1, the lower twin, is trophoblast is embedded in the niche, and that pregnancy also failed, and this patient had an elective section for twin 2 with a small PPH. This case is a posterior placenta showing that a scar pregnancy can become a posterior placenta. You can see here this is a scar pregnancy. It fulfills the criteria, and even this early at 6 weeks you can see evidence of posterior placentation, but the trophoblast is tucked into the section scar. By 8 weeks, again, it's noticeable the trophoblast is in the section scar, but there's more placenta developing posteriorly. And that remained the case, and the placenta was very posterior, but it went up and over into the section scar. And this lady again ended up with a Caesarean hysterectomy, a large PPH, and it was Placenta Accreta. When you get bulging, this can be a bad sign. This patient with a poor obstetric history at 8 weeks gestation had a scar pregnancy, and you can see it here with an empty cavity above and an empty cervical canal. And at 10 weeks she had more bleeding and more pain, and you can see this is the scar pregnancy. It's live. This line, if you draw from cervix to anterior uterus, you can see that the pregnancy is bulging toward the bladder. And on this video clip you can see that that is a very abnormal placenta with a live scar pregnancy in the center of it. And look at the vascularity, very, very strong indeed. 2 days later this patient opted for surgical management, but this resulted in a hysterectomy, heavy bleeding and placenta accreta on histology. What you can also sometimes see is where the scar pregnancy develops a fistula with nearby large vessels, and in this case this patient had had 1 previous Caesarean section and she developed a scar pregnancy. You can see it's tucked into the section scar that bulges out toward one side. This is longitudinal little video clip going from side to side, and you can see that on that side it's normal, but toward the right side the pregnancy bulges toward the right side. So you can see this is the 3D view. This is the scar pregnancy, and it's bulging out toward the right. It was very, very vascular, this scar pregnancy, and here this is the uterine artery, and you can see a direct connection between the two. And this is it on a little 4D clip. So 3D with movement. You can see the uterine artery, and you can see it directly connects with the trophoblast, which is so extremely vascular. The patient opted for conservative management and was given some depot, and a couple of months later the trophoblast was still there. It got slightly smaller, and 5 months later the trophoblast was still present, but again it had reduced in size. The patient remains asymptomatic and is being followed up. So we now know what a Caesarean scar pregnancy is and the difficult things to look out for. But there's a little bit of controversy here about an in-the-niche scar pregnancy and what to call on-the-scar placentation. So in 2016, the definition of a scar pregnancy is had to be at the site of the scar with thin or absent myometrium. And this paper in 2017 came up with an in the niche scar pregnancy, where if the myometrial thickness was very thin, these people would develop placenta accreta spectrum. So that's what we've been looking at. But also talking about on the scar pregnancies, where the placenta was implanted partly or fully on top of a well-healed scar. And if the myometrial thickness was more than 4 millimeters, this was shown to have good outcome. Like here, you can see a thick scar and the placenta implanted over the top of it. So should we call that a scar pregnancy? In 2020, ESHRE came up with some new terminology, and it said definitely that a scar pregnancy is implanted in the niche of a scar. It's close to the os, anterior implantation, invading the myometrium, and with color Doppler in the scar. So if we're going to call it on the scar, maybe just on the scar placentation rather than scar pregnancy. Here are 10 examples from our practice, and in yellow at the top again is the residual myometrial thickness, and you can see that they're all over 3 millimeters. These patients delivered all after 29 weeks, 8 by Caesarean section, 2 by vaginal delivery, some PPHs, but the average blood loss much smaller, and no hysterectomies in this group. So this is one example. So this lady had 2 prior sections. She had the placenta is overlying the thick scar, 7.5 millimeters, had some bleeding. The placentation was embedded at the site of the scar, and you can see this little video clip. It doesn't move, that the placenta is embedded into the scar. The uterine cavity, there was still a little bit of emptiness above it, and the cervical canal was empty, and the cord was inserted anteriorly. So yes, empty cavity in cervix, embedded at the site of the scar, functional trophoblastic circulation, but the myometrium was not thin, it's 7.5 millimeters, so probably we should not call this a scar pregnancy, but call it on the scar placentation. This patient had a section, 29 weeks for bleeding, and there was no placenta accreta spectrum. So I'm going to say if the placenta is attached into a thin-walled niche, I'm going to call that a scar pregnancy. But if the placenta is attached onto a thick scar, that will be on scar placentation. So the question is when you call it on or in, and this is a very early scan. You can see just 5 days late, there's a tiny little gestation sac there at the level of the scar. By nearly 6 weeks, still the pregnancy is there and the scar thickness is still 4.5 millimeters. But by 8 weeks, it's a very different picture. You can see here that the trophoblast is embedded into the niche of the scar. The vascularity wasn't very strong. It was repeated again, and here now you can see much more clearly the trophoblast goes up and into that niche, and it is embedded in that area. And these are the images from the rest of the pregnancy. This patient had a Caesarean hysterectomy for heavy bleeding and had placenta accreta. So what we thought originally was an on scar placentation, by 8 weeks was an in niche scar pregnancy. So give it until at least 8 weeks before you make your mind up. So what are the differential diagnoses of a scar pregnancy? Of an in niche scar pregnancy? Could be low implantation, that the placenta is near the section scar, could be a miscarriage in progress, or it could be a cervical pregnancy below the internal os in the cervical canal. So let's look at those. If it's low implantation, as in this case, we could see here that that here is the scar, there is the sac, empty above and empty below. This is it at 7 weeks with some color Doppler flow, 9 weeks, 11 weeks, still anterior. But later on this placenta moves up, as you can see, and she had a forceps delivery. So how could we know this was not an on-scar placentation? It's the presence of decidua. If you look carefully, you can see some decidua between the scar and the gestation sac. So if you can see that, then it's near the scar, not on the scar. It's just low implantation. Or miscarriage in process. Here we go, there's a thick scar. Here's a low pregnancy, empty above, empty below. Not much vascularity though, and it was uncertain viability. And a week later, when we pressed gently here, this gestation sac was sliding around the endometrial cavity, still not much colour if any there, and after medical management, this pregnancy resolved spontaneously. So how could we have known this was just a miscarriage? Well, there wasn't any vascularity there and it was sliding. So that's a miscarriage in progress. A cervical pregnancy is in the cervical canal, as in this case here we've got the internal os where the bladder attaches to the front. There's the internal os. This is the cervical canal, and this pregnancy was in the canal and it's anchored in the cervix. A week later, this pregnancy started to fail and eventually, with conservative management, resolved. So if the pregnancy is below the internal os, think of cervical pregnancy, but these are very rare. And something that we're seeing quite often now is a little fibrous section scar hematoma. This is an anterior view, anteverted uterus, and you can just see this sort of blob at the level of the scar. The scar is just there, and if I rotate on it to transverse, you can see again this was probably a hematoma and it has healed into this fibrous lump on the outside of the uterus, so that's not a scar pregnancy. So in summary, if you have an empty uterine cavity and an empty cervix, the trophoblast embedded at the site of the scar with thin or absent myometrium and functional color Doppler at 0.9 kilohertz, that's an in-niche scar pregnancy. But be careful with pregnancies that are on the scar or near the scar. The Scar Pregnancy Registry has been set up, collecting data on as many scar pregnancies as they can get, so that we learn about the natural history and about how to manage such patients. So there are 6 centres already contributing data, and we're one of them. And if you'd like to join them, please message them through the website. So in conclusion, you should always ask your patient if you're scanning her if she's had a previous section. You need a good machine. The niches and scars can be difficult to see, and this varies with gestation. The pregnancy fills the uterine cavity by about 8 weeks, and it's much harder to decide if something's a scar pregnancy after this. The residual myometrial thickness can be difficult to measure. Don't include the trophoblast or the bladder, and look for decidua between the gestation sac and the myometrium. Look for the teardrop in the little triangle, that's very useful. And be very careful with thin overlying myometrium, particularly if it's less than 2 millimeters, because these patients are at very high risk of Placenta Accreta spectrum. Look for strong colour and for bulging, and get the scan repeated by experts if you're not sure what's going on. Remember that an apparent on-scar placentation can become an in-scar pregnancy. You need to scan at about 8 weeks to tell the difference. But that an on-scar implantation might just be a low normal implantation if you can see some decidua. And it probably isn't one single entity, this scar pregnancy, but more of a spectrum. So record the early pregnancy findings in the obstetric note so that at the end of pregnancy people know what you thought earlier, and make it easy for the obstetricians to see the early pregnancy images, because it will really help. And even if you said it was a scar pregnancy in the first trimester and the second trimester scan doesn't show Placenta Accreta spectrum, the placental bed may still really bleed at the time of delivery due to these large vessels in fibrous scar tissue which can't contract. And I'll leave you with this penultimate publication from the MBRRACE study published in 2018, saying that there'd been a near doubling of the maternal death rate from hemorrhage, almost entirely due to this abnormal adherent placentation. And the recommendation is that people who've had a previous caesarean section, who have placenta previa or anterior placenta near the scar, should be managed as if they have Placenta Accreta. Thank you.